Everybody. Good morning. Good morning. Hello, everybody. Welcome to this month's Implant Threads. This morning I've got Manoj, who is one of the pillars of VSS Academy, talking about mentoring and clinical residency as well, and what it means to students, but also to those that do implants in their own practices. So, Manoj, I'll hand straight over to you, and we'll get started. If there's any questions that anybody has, please feel free to put them in the chat, and we'll address them as we're going to go along. We're just going to keep this sort of nice and light-hearted and kind of informal. So yeah, if anybody's got any questions, just please pop them in the chat, and we'll get to them as soon as we can. So, Manoj, over to you.
Thanks, Sean. Thank you. And good morning, everyone. We have obviously been running implant threads for some time now. And a lot of topics are clinical. So this is a little bit different. It's about mentoring and clinical residency. And really what I want to do today is take you through a very practical and honest look as to how you can move from your theoretical knowledge in implant dentistry to genuine clinical competence and confidence in a sort of a safe, but in a structured way. So very, very briefly about me, I've been doing this for some time now. And alongside Fadi at the university, we've been running the MSc till about 2025. And what I mainly do is kind of wear different hats. So I spend about 3 days in a week in the practice, placing, restoring implants, organize clinical training, if you like, teach with VSS Academy. But importantly, I spend about 2 days a week, and I've been doing that for a long, long time, just mentoring colleagues and implants. And at a given time, I work with about 15, 20 dentists spread all over the country, really. So it gives me a fair understanding, if you like, of the challenges that clinicians face at different stages of their implant journey. And also as a training center lead in my practice in Kenilworth, we do the most structured in-house form of teaching and training. Currently, we've got about 5 students doing the masters or finishing the masters at the university who are with us doing their clinical training. So, and they go through the whole stage with us. They go through examining, treatment planning, CPCT reporting, surgical, restorative, all in one-on-one mentoring. So yeah, there's a lot of teaching and, more importantly, clinical training in implantology that I'm involved in, both as a visiting mentor and in practice. So coming to this implant mentoring business, and that's what it is about today. What is mentoring in implant dentistry? Why do we need it? Why is it needed? And how do we go about it? And why we feel that mentoring and residency should be essential in your journey from starting and progressing in implant dentistry. And really, this session is about clarity, really. There's a lot of information out there, a lot of courses. And my aim today is to try and simplify this for you. Can we take this clinical knowledge that's out there in various shapes, size, and form, and transfer that to a safe clinical practice in this field, which is a complex field, really, of implant dentistry, and also curate this sort of clinical training to your level, identify your skills, both prosthetic knowledge and surgical skills in implantology, and then to grow it to reach a level of safe, high competence. That is what this chat is about today. So what is it? It is structured clinical guidance, really, real case-based learning, and more importantly, on your cases. We support you and take you through every stage of treatment. and gradually progress it from straightforward to advanced and even complex cases. And the point being to take you from theory to safe clinical practice. That is what mentoring is all about. And it's not just about learning how to place an implant. Um, Many courses will teach you that. Even we teach you that as a part of a certificate course. What mentoring really focuses on is pretty much on everything around it, uh, from case selection, planning, decision making, and importantly, knowing your limits. Um, and that is critical. You need someone alongside you to understand that it's very, very easy to slip and get into trouble. It really needs you need someone to guide you, if you like, through real cases. Again, I say your cases, and help you make the right decisions at each stage. And it's a gradual process. You're not expected to jump into complex cases. You need to build confidence step by step with support until you reach a point where you can work independently. So, in really simple terms, mentoring, in my head, is about bridging that gap between theory and safe, and this important, safe clinical practice. Safe for the patients, that is critical, and safe for you. Um, so let's move on as to why. Why is this needed, mentoring? Do you need this at all? Um, there is a legal angle, if you like. Um, the General Dental Council, they don't have their own training standards in implant dentistry. They follow the FGDP training standards, which I think started in 2002 or 2004 and was finally updated in 2016, and it's still being updated. FGDP, which is the Faculty of General Dental Practitioners, um, don't exist anymore. And the College of General Dentistry has taken up that mantle. And recently, a couple of years ago, maybe a year ago, FGDP, the College of General Dentistry, and ADI working group came up with their document of mentoring in implant dentistry. And this document sets sets both sides. It sets requirements for mentor, who should be the one mentoring, and what are their clinical requirements, their knowledge and training, and for the mentees. And there are rough figures out there. There's always a figure out there, never written in stone, of the number of cases. A lot of people ask us how many cases. I remember the diploma, the RCS diploma in implant dentistry, the Edinburgh one. Uh, you could sit the diploma exam with about 15 cases under your belt, mentored cases under your belt. This is going a few years ago. That has changed recently. But what the College of General Dentistry is recommending is about roughly 20 mentored cases, mentored documented cases, where you have what we call as the whole DOPS, the direct observation of procedure, where you are signed off for every step, and you reflect on each step. And of course, maintaining, therefore, a logbook of these cases. So if going forward, unfortunately, one gets into any kind of trouble, it is these documents that the GDC would look at when they assess your competency uh, to be able to provide implant treatment to your patients. So that's one angle. But I consider it the so-called legal angle. But there is also a bigger angle. It is the practical angle. And I'd be a bit controversial, if you like, here. Implant dentistry in the UK, for sure, and in many other countries all over the world, um, is kind of um, ad hoc. It's not taught at an undergraduate level. And that is scary. Um, in the UK, it could be a bit of a Wild West. It is staggering to imagine that you can become a dentist with little or no knowledge in this field and certainly no experience, and are still expected to be able to identify uh, and manage implant based problems in your practice. And not being able to do this can get into a lot of troubles, opens you up to supervised neglect, if you like. The thing is, this learning, which doesn't happen at an undergraduate level, is kind of almost self-directed. And yeah, even social media driven massively. Um, it is to be done by dentists when they come out themselves. So you decide once you come out, what kind of course do you want to do to learn about implant dentistry? You could do a short 2 or 3 day course, or do a 2 or 3 year course from diplomas to masters. Um, and ideally, this should be something that should be written in stone. It shouldn't be left to clinicians to decide what level of courses do they want to do to be able to practice implant dentistry. And that is the worry that we have. Now, implant teaching itself, in my opinion, can feel a bit disjointed for someone who hasn't got any previous knowledge um, of implantology or has some knowledge driven uh, by these various platforms. Um, and the reason why I say it can feel disjointed because there are a lot of concepts out there. There's rote learning. You learn about bone types, etc. Early, immediate, delayed placements. There's so much out there. Now, the point is, there are concepts, there is that knowledge base, but it is only when you put this into real practice and in clinical cases, and I keep repeating your own clinical cases, that the jigsaw starts to fall into place. Mentoring, and more importantly, we feel clinical residency is the way to becoming a safe clinician where evidence based knowledge actually moves to evidence based practice. Now, the big concern in all of this is the sheer inability for people getting into implant dentistry to see the end goal of this complex treatment. Uh, a lot of people look at bone, try and place an implant there, but they can't see the prosthesis. They can't see where the prosthesis should be sat, where the crown should be sat, how the force should be directed down that crown so that that implant is placed in a position where it can absorb that pressure pretty much vertically down its long axis. To see that whole picture, and somewhere in between all of this, bone, implant, crown, force, sits the gum. Where should that gum sit? How does one create that gum profile? All of this is difficult to imagine till you actually don't get your hands dirty and treat patients in a safe, structured manner. The point being that having a mentor alongside you, the mentor could potentially see these pitfalls uh, where you can't. You simply can't. I use this term of angels fear to tread where fools rush in. I've actually gone about finding a reference for that. It's Alexander Pope in 1788 who made that statement. And really, that's what it is. If you can't see the pitfalls, then you'll get into trouble. And for me, avoiding a problem is a lot better than dealing with one. And if a problem does come out, then with the mentor hand holding you, that element of managing that problem becomes critical. So, yeah, in a nutshell, problem solving, I believe, starts from the first stage of case planning and to avoid getting into it to begin with. We look at, for example, we follow the ITI protocol. Um, and there's a simple tool out there. You don't even have to be a member. You can jump in and see the tool yourself. It's called the SAC tool. It stands for straightforward, advanced, and complex. And we look at 4 different domains. We look at the aesthetic risks, we look at the surgical risks, we look at the maintenance risk, and we look at the prosthetic risk. And what ideally we sit and do with our mentees before we even jump in, before we even um, write a report to the patient to consent for this process, uh, is we go through these risks with the mentee. So you could, for example, have, say, an upper anterior, upper central incisor that's missing, and you're replacing it. That case, by definition, being in the aesthetic zone, from the aesthetic risk factor is advanced, if not complex. If the patient is discerning, complex. If it's a high smile line, it becomes complex. A thin gingival biotype would make it complex. Long-standing tooth loss, a lot of buccal wall loss would make the case more complex. So aesthetically, an upper central incisor placement or implant treatment from an aesthetic point of view could be advanced or complex. Restoratively, it might be straightforward. It's the front tooth, you can restore it easily. It's probably not taking a lot of biting load, maybe some degree of anterior guidance. So restoring it could be straightforward. Maintenance could be very straightforward. It's a front tooth, easy enough to clean, maintain, especially if the patient is not periodontally compromised, because that automatically increases the maintenance risk for the patient. Surgically, it is advanced and can very easily be complex. You have the mental foramen behind, not the mental, sorry, the nasopalatine just behind the site. You lose it in a few months, you lose tremendous amount of buccal bone and you lose vertical bone height. So this could be a case that might need a two-stage process: graft first, wait, then place your implant, or place and graft at the same time. But more importantly, somehow try and get the implant long axis such that it comes through the cingulum. Now, all of this are risks that one needs to identify. Once you've identified this risk, try and find methods to drop each risk. So if aesthetically you're in the complex field, try and do something to make it advanced. If you're in the advanced zone, try and make it more straightforward. And that is how we work with our mentees. We try and get you to identify the risks in your case, then try and set systems into place which keep dropping that risk. And as you keep dropping these 4 risks, the cumulative effect is long-standing success. That is what we are after. The problem, again, we face, as I've said repeatedly, is when you're getting into implant dentistry, you simply can't see the forest. You're looking at trees, you're looking at bone, but you're not seeing the entire picture. It's difficult to see that till you do a good few cases, ideally from start to finish. And the most important learning curve comes when you are fitting that implant crown. That is when you realize, oh, I should have gone more palatal. I should have gone more mesial, more distal. I wish I'd gone a little bit more deeper to get my implant in the right place, to get the right crown margin, to be able to get the right emergence profile. Or maybe I should have just adjusted the tooth next to it. If the tooth next door, see, you're placing a lower 6 and the lower 7 is ever slightly tilted, you could just shave it, upright it a little bit, so you get good proximal contacts. Until you don't restore these cases, you don't know what you've done wrong and what course correction you need. And this is the critical element of having a mentor by your side to be able to see that end result and then to change each step so that the whole case dovetails perfectly well. Let me show you this, for example. This is a case, a patient of mine. Well, when I say mine, not my patient as such, was referred to me. But we've been seeing this patient since 2011 at a Halesomen practice. Now, she already had these photos and the x-rays I'm showing you are maybe last year or the year before. But we saw the patient first in 2011. And at that point in time, she had the upper left 1 present and had a 2-unit bridge replacing the missing upper left 2. So upper left 2 was missing. Upper left 1 was present. She had a 2-unit bridge at that point in time, 2011. And she had 2 implants on the upper right 1, upper right 2. Now, if you look at these bone levels, and as you can see, those 2 implants have been well splinted together, and it's got cervical ceramic to mask that degree of tissue loss. This bone level, believe me when I say this, has been exactly the same from 2011 and now. Nothing has changed. Around those 2 implants, there is no inflammation. There is no bleeding. There is no separation. There is no discomfort, although it looks inflamed on these photographs. And strangely enough, this patient is pretty happy with it. She doesn't want anything changing. So really, all these years, we've just been maintaining it. We came across a situation where she had to lose the upper left one. Um, and what we've done here is placed one implant and made her a 2-unit bridge. So the point being, this case, although the patient is happy with it, which tells us that the implant treatment has gone well. As far as the patient is concerned, it's successful. For us, it's just surviving. But the point here being, that was this when the initial treatment was done in 2011. Well, we saw 2011, must have been done a few years before that. Was it an issue with the planning, or was it an issue with execution? And that is what we need to think about. Were 2 implants needed? Could 1 implant 2-unit bridge be fine? Was it required to join the 2 crowns together? Could it have been kept separate? And you can see that between the 2 implants, there's a lot more crestal bone loss, which has therefore caused a black triangle and more soft tissue loss. The tilting of the implants, should it have been in a better position, etc. Now, the better position could be an execution issue. Placing 2 implants and splitting them together could be a planning issue. And that is where the mindset starts to change. Now, having said that, please bear in mind that implants have been there since the 70s, 80s, got a bit more popular in the late 80s and 90s. I have been placing implants 2001, so I'm one of the oldies, if you like. And honestly, we didn't know what was best at that point. Implants were so new. Problems around implants, the definition of peri-implantitis, for example, has been nailed in 2017. And dealing with it is a different issue altogether. So yeah, we have learned things as we go along, and technology has improved. We've got CBCTs. We can do virtual planning. We got guided placement. There's a lot out there that has changed. But this particular case, for example, and we see a lot of these cases happen even now, is the mindset. Is it a planning mindset, or was it the way it was executed? And that is where we all, when we start off in this field, and even progress in this field, need a degree of hand-holding. We have colleagues who have been doing implants for some time, and they come across a case, and they say, right, we just need an online planning session where we just sit with them, do a deep dive on the case, and just plan the case online, and they execute it. So this is very, very flexible, if you like, mentoring as a model. And I hope that gives a flavor of what we face on a day-to-day basis, and the need, quite frankly, to have someone by your side who can hopefully see the end result with more clarity than you might be able to at this point in time in your journey with implant dentistry. Because at the end of all of this implant needs to be prosthetically driven, and it is a different beast. Every time we chew, all teeth in the mouth bounce up and down, move left and right. That implant, without a PDL, just stands there rigid. And that is where prosthetically driven implantology comes into place. You have an ankylosed, immobile unit sitting in your mouth, and a mouth is full of everything that keeps moving, morphing, changing shape, position. So placing this implant in the right manner for long-term survival and success is critical. So let's move on from the why to the how is it done. How does the mentoring process actually happen? Now, this is pretty much open to everyone of varying degrees of experience. It is ideal for mentees with some implant experience, don't get me wrong. Maybe not for zero implant experience with mentoring, because mentoring is an in-house process. Now, it is a hybrid model. The case assessment and treatment planning happens online. And we have enough tools to be able to get that and nail it properly. You've got intraoral scans, you can get photographs, you do your whole case assessment, medical history, dental history of death loss, the extraoral examination, get study models made, radiographs taken, and that is when you share the case with your mentor. And based on that information, forget about the CBCT for a second. Based on that information, if the case, the decision needs to be made whether this case is a go, no go. Only if we feel at that point that yes, this case is reasonably to progress with, that we go next step and get CT scans done. Once that is done, that's when the online planning starts. We book a session with you, we sit down online, and we plan the case. We identify the risks, work out how to drop it, then send a report off to the patient with all the pros and cons, whether graft is needed, not needed, what type, etc. Then the surgical phase comes into play. That's when we book a session with you. We'll come into your surgery and we'll do the surgical placement of that implant and any other procedure around, whether it's a graft, simultaneously, an internal lift, whatever it needs doing, is done together. We would, while we are there, plan out what our exposures would be like, what a lab prescription for this case would be like, and then we leave you to carry out the restorative process yourself. Yeah. Now, this is open, really, as to begin with, mentees with some implant experience, but also, quite frankly, a lot of our mentees tend to be dentists with special interests, not just general dental practitioners. We have a lot of experienced general practitioners, general dentists who want to get into it. We have oral surgeons who we mentor. We have prosthodontists that we mentor, periodontists. We have all sorts of specialities who jump in. Because in all these specialities, implants are covered, don't get me wrong, but they're covered from that angle. Oral surgeons are notorious, and apologies to those out there, because their implants tend to be quite bone-driven, if you like. And they struggle sometimes, and they're uncomfortable with the prosthetic side. And that's the reason why they need mentoring for the planning, even for the execution. They would lift, I work with oral surgeons who would raise a flap and put it back in a minute, can do all sorts of drilling, no problem. What they worry about, and quite rightly so, is where are they placing their implants? How are they angling their implants? What depth should it go to? And so on and so forth. All of that to get the prosthetic outcome. So again, mentoring is a hybrid process where a bit of this happens off-site, the surgical bit happens on-site, and we would support you again off-site for the remaining stages, which is your prosthetic stages. Now, that is mentoring. Also, apart from this, mentoring could be for specific parts of treatment. So, for example, you could have colleagues who are comfortable placing implants, straightforward, advanced, but they might need mentoring for the complex stages. So the mentor could come in, for example, to do a block graft, for example, to do a lateral sinus lift, for example, and that they would do together, and then the dentist would, or the implant dentist would, then the mentee would, after X number of months, go ahead and place the implant. So it is a very flexible sort of an approach. On the other hand, comes clinical residency. Now, clinical residency pretty much is an end-to-end service. So instead of us coming to you, you come to us. We provide the patients, we provide the materials, we provide the nursing staff, and everything. of course, the right cases. You come to our centers, and we have multiple centers up and down the country. These centers have been involved um, in training students for their masters, for their MScs for many years. The trainers within the centers are trained, if you like. Not only are they very experienced implantologists, but they are also vetted, they are also audited. We look at all our training centers. We meet once a month, and we pick up issues if a particular training center has had with an aspect of training, and we are able to then alter within all our practices. If there is a learning need, a learning curve, if you have a learning point that comes out of a particular aspect of us training you, all our trainers can then modify their approaches if required. So there's a lot of training the trainer or auditing the trainer and the training center that happens behind the scene. So you go into centers like these, and we get you to place 10 implants from start to finish. Now, mind you, 10 implants could be 10 cases, could be 7 cases, could be 5 cases, but 10 implants, which is a decent number to start with. Are these implants that you're going through the whole shebang. You're going through assessing the patients. The implant consultation for these patients tends to be about a couple of hours. You would assess the patient and present the case to us. You are marked on that case presentation. We would then follow it up with special investigations, study models, CT scans, etc. You would then do a CBCT report, which again you're marked for. And you reflect on. It's not just us marking you or grading you for every step you do, which is critical, but it's also you reflecting on every little thing that we mark you on. You would then follow this up with a full implant report to your patient. Go through the whole consent process. And once you're done with that, comes the placement. It could be again place and graft, or just graft and not place a bit later. Whatever surgical treatment that's needed, soft tissue work, whatever else that's needed in that case. Expose the implant a couple of months later. And again, this is a critical step. I know a lot of us put a healing abutment, walk off, which is fine. In many cases, we would do that. But in some cases, submerging the implant, quite frankly, I do in most of my cases submerge my implant. Exposing an implant, different methods of exposing an implant can be game-changing for soft tissue around it. Scanning the lab prescription. It is such a critical element. What do you tell your lab to do? You don't want to just place an implant, do a scan or an impression, and tell the lab zirconia crown A2, and that's it. You need to describe, if you like, or prescribe to that lab where you want your implant crown margin to start. What emergence profile or what emergence angle that is needed? Where should the proximal contact be? What kind of occlusal scheme do you need to give to this implant crown? Is it screw retained? Is it cement retained that you want? You prescribe the crown. You don't just ask the lab to do it. And of course, then fit it. So you would take 10 implants placed and fully restored and then reviewed. You would have a case logbook, your DOBS or direct observation of procedure, as we say, marked for all stages. And we can curate this as we go along because and it's not a time-based thing. You could do those 10 placements over 3 months, over a year, it doesn't matter. So it's not a time-based thing. And ideally, we'd like to spread it out a little bit. There's a reason for that. As I say, once you start restoring your implants, you start course-correcting your placements. And we can then curate it. We understand your skill sets. We can up your skill sets if required. We can tell you, no, this is fine. Do not do anything. Don't make any changes. And we can curate it and move you then from straightforward to advanced cases. You might be doing straightforward cases, in which case we would push you quickly to advanced cases. What we try and avoid in a clinical residency, if you like, is truly complex cases. We don't try and jump into that as far as possible. So if there is a high complexity, because at the end of all of this is patient safety, the patient comes first. That is the critical element in all of this. So we need to be confident in your ability to do that complex work. If you are able to, then by all means, we might throw some complexity in it. But what we're looking for is for you to have a protocol and have the skill set to do your straightforward and advanced cases, which for all practical purposes, and I do implants every day of the week. It's pretty much 90% of all your cases, if not more. The only time it turns complex, really, is if it is a two-stage process. You need a, a, a major bone changes, horizontally or vertically, block grafts, vertical grafts, or sinus grafts, etc., which by definition becomes a two-stage process. So if your case needs such a thing, you would work with us, where we might execute the complex bits of the case. Even in lateral sinus lift, for example, we might get together. You might raise the flap. We might open the lateral window and elevate, and you might pack the bone in. You would then close up. So you get a very in-depth insight into the complex bits. And once that's done, you would then take on the case and place and restore. And that is clinical residency. So it's end-to-end, if you like, service, um, as opposed to mentoring, which is the one-on-one happens only in the surgical bit. So just a very small, simple difference between mentoring versus residency. Mentoring is more practice-based, your practice-based, or you get the patient to us for that particular surgical aspect, while residency is more clinic-based. Mentoring is more flexible. There's flexibility built into this program. You could just be doing online sessions and do the case yourself, and so on and so forth. Residency is a structured format. And for those of us trying to get into implant dentistry, our advice would be to consider a residency program and concurrently get the mentoring sorted. So you're almost having, so if you spend time on the residency program, which could be 6, 8 months, 9 months, 10 months, a year, you could also at the same time in your own practice be doing some cases where you're getting mentored for. So all in all, by the end of that period, 6, 8 months or a year of clinical training, you could have with us 10 implants under your belt, and you could yourself in the mentoring do another 10, another 20. It doesn't matter. But you always have that mentor with you on both sides. I'm not sure if I have put John to sleep at this point.
No, not at all.
No, okay, because I've been droning away. So what I will do is stop droning at this point and get John in, because really, and I'll introduce John to you. John was with us doing his MSc at UCLan. When was it, John? A few years ago, isn't it?
Oh, no. Geez.
Many, many years.
It was after COVID,
I was after.
2022 to 23, I think it was.
Yeah,
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 21
yeah.
to 23.
Yeah, so at that point, we would do our 15 clinical days as a part of the MSc program. And really, this is a similar thing what we're doing with the residency. The difference being that we're doing a defined 10 implants. But I remember, I think, John, you were not, or you just got into implants at that point. You were not doing many.
No, that's yeah, that's right. So yeah, I had my own practice, well, still have my own practice, but we weren't doing any implant work, and it was something that I wanted to sort of pursue and get involved with. So yeah, that's how I ended up doing the MSc.
And to complete my introduction at this point with John, at this point, he's been placing, restoring. I think he's been doing quite a bit of it now. And he
Yeah.
contacted me the other day and dragged me in, screaming and shouting, to do a lateral sinus lift together. So it's been a
Yeah.
big thing. And for me, I don't know, because I saw both sides. I saw what we were doing together in 2022 and now in 26. Your skill sets were through the roof. Uh, I, I, I was just sitting around doing pretty much nothing,
Yeah.
except for just little bits with the sinuses. So I'll pass this over to you, John. As I say, I promised to stop talking, so I'll stop talking for a few
Yeah.
minutes to just give us a flavor of what you feel about.
Yeah.
I'll stop talking. Over to
Okay.
you, Miss.
So yeah, so I my approach is that, I don't have as much experience as Manoj, and it's realizing that, and just because you can go on to an MSc, or you find yourself doing a sort of an implant course, doesn't mean that it may not be suitable for you to be placing implants in your own clinical practice. So mentoring was part of the reason why I ended up with VSSAcademy and doing our MSc program, because I knew that we had that mentoring afterwards as well. And I'm quite happy doing sort of type 1, type 2, type 4 placements. We do those fairly routinely now. I do grafting in 95% of my cases, and I do a bit of block grafting as well. I don't tend to do an awful lot of sinuses, and that is something that I am aware of. So if occasionally when one does come up, I have approached Manoj, I have approached Fadi as well, and we've worked through those cases together. Um, and it's for me, it's not because of the GDC requirements, or what the ADI say. For me, it's about patient safety. It's about still having that learning aspect as well. We're all continually learning, um, and just to have somebody there, just to stand by you, and sometimes it's just little things, just to say, just hold that back slightly further, just push this away. Can you see that? Can you do this? Little things make a huge difference, and that's what I find the value of mentoring, is that it's to have somebody there on an ad hoc basis, that we can get that case sorted together, and achieve the best outcomes for the patients, alongside of learning, and then also spending time with Manoj as well, which is always fantastic. Um, so yeah, it is invaluable. Um, and then subsequently, since we did the sinus, we've spoken a couple of times about the patient, just making sure that she's okay, checking in and things like that, and I will bug Manoj till we fit that crown, just to make sure that he's okay with everything, and I will send him a radiograph on a Friday night and go, "Are you happy with this? I'm happy with this," but just making sure you're okay, and it's that sort of thing. It's making sure that there is that sort of communication. Um, so yeah, it is important, and I think residency massively is important. Like Manoj was saying, this isn't taught as undergrad. There is a massive problem with that, and to find something that can offer a residency to give you the best experience, to help you go from, whether it's, you've never placed an implant before, or you might be quite happy placing implants, but you've never grafted before, to, oh well, the more complex things as well. Finding something like that, which is, that has a decent um foundation, that has all the checks and balances in, and that can help you and lead you, I think is massively invaluable. And I know that sort of here at VSS, Manoj has been very involved with our clinical residency that we've been setting up, and it's absolutely fantastic. And I'm not sure if you want to speak a little bit sort of about that, about how we're sort of developing it. I'm sure Alan will love that. But yeah, it is what it is. We all have to learn to progress, and to achieve the best outcomes for our patients, but also the best outcomes for us as clinicians. So yeah.
Yeah, and to not feel all alone, because
No.
dentistry is quite a lonely field, isn't it? You just sit around
Yeah.
dealing with your patients in
Yeah.
that little dingy clinic of ours. Uh, and when things don't go, you're not sure about
Yeah.
something. It's it's invaluable just having
Yeah.
just being able to text or call someone saying, "Mate, listen,
Absolutely.
can you give me some advice on this?" Um, I do this with colleagues. I do that. I mean, I text
Yeah.
Fadi out of the blue, say, "Fadi, listen, what do you think of this? What should I do?"
Mm.
And at every point in time, I've been doing implants for 25 years and I still keep asking. It's the thing that you're not alone.
Mhm.
You're not alone. That's the main thing. Um, and with the progression that John mentioned, um, yeah, we've got basically this is how uh, we run it. You've got three levels, if you like. You got the first level where someone does a course in implant dentistry. It's called the Certificate of Implant Dentistry or the CID, which is level one. And now in level one, if I'm not mistaken, you get to place a few implants on patients. So you are assigned to a clinic and you actually get to place a couple of implants at level one. I think there's two or four. I think now we've
I
added.
can't remember the numbers
Yeah,
myself,
so
but yes, yeah.
so don't rat me out because Alan would text me now and shout at me. But I know it's at least two. That's with the CID. So the entire theory, CBCT training, the whole shebang spread over a year, if you like. Normally, it's a hybrid model. So again, you have online teaching, you have face-to-face teaching. What we used to do as a part of the CID program, do a cadaver course, which is brilliant. It's 1 day cadaver course. Um, but we've swapped that because people wanted that clinical feel, and we moved that to getting in clinics to place a couple of implants. Um, the next level is what we're talking about, is the clinical residency. We have That's what we developed now. We have well more than 10. Is it more than 10 centers, John, up and down the country?
Yeah, we've got quite a few
Quite a
now.
few.
Mm.
And you can be assigned to, but depending on your geographical location, you might want to do in a couple of centers even. So it doesn't matter whether you're doing it in one or two centers. So you have different trainers to get different levels of input coming in, different thought processes. You could do it in one or two centers and do up to 10 placements. And that, as I say, takes you through the whole thing from examining all the way to finishing. And what we highly recommend, along with the clinical residency, uh, consider being mentored in your own practice. So your own team, it's not just you doing it, it's your whole team doing it, gets up to scratch and you get your numbers up. Um, and the third level is the level three, which is for complex cases. Um, and that is something we're developing now as we speak. It's out there already. Um, so if you are reasonably experienced, you've done 50, 70 under your belt, you think, okay, I want to jump into a certain degree of complexity, and you pick and choose. You might want complexity on hard tissue work. You might want complexity on soft tissue work. Then that is almost curated to what you need. And that is level three. So that's the third level. But yeah, level one, level two, along with mentoring, pretty much covers 90-95% of all your cases. But it's important to understand that you're not in this game alone. It is a complex field. Um, Litigation, as we all know, is at its all-time high. And you want to do it right. You want to progress correctly. You want to do it safe for your patients, safe for yourselves. That is a critical message. Um, and really, to finish off, you could be at different stages of your career, your dental career and your implant career. And this is for pretty much everyone, if you like. New to implants for sure. Uh, uh, for experienced GDPs, freshly, when I say freshly, at least 2 years post grad. It's also for other specialities. Oral surgeons might want to know more about the prosthetic elements and might want mentoring from that aspect and vice versa. I am attending a course. I don't know, John, did I tell you? I'm attending a course with one of my colleagues, a specialist prosthodontist, because there's certain things maybe I've got to get more modernized. I'm attending a
Mm.
modern course. Um, so yeah, it never stops. It is for people who've done courses but lack confidence, and for those of us who want predictability. Um, that is critical.
Sure.
Um, so to finish off, yeah, arrange a discussion. Um, any one of us are more than happy to discuss it in detail, and explore a plan. See what's good for you. Um, so yeah, that's us, VSS Academy. Give us a shout. Um, Alan is your go-to man with all sorts of information. Um, I'm I'm available. Just drop me an email, and I'll try and get back to you as soon as possible. And let's just have a chat. Um, and thank you so much for spending a Saturday morning, which at least where I am in Rugby is bright and beautiful, um, on this webinar. I'll stop talking and take any questions if anyone is still alive and kicking.
Fantastic. Thank you, Manoj. It's been a really nice run through of what VSS offer and what you offer as well. Um, I find that sort of I've had some input with the clinical residency program, which has been really interesting, and it is fantastic to see how it's being developed. And I think sort of from the level one to the level two, I think is going to be stellar. The level three for those experienced clinicians that want to do a little bit more, I think that is going to be a really valuable investment for people in terms of their time and everything. And it's definitely something that I probably am a little bit biased, but I know that I'm going to be doing it, because I really want to push for that, and I think it'd be really good. Um, I know Anil has asked what is the cost of residency. Anil, I would say if you have a chat with Alan directly, he'll be able to tell you that. I think it is all on the website, and I think that the Alan bot, our AI generated version of Alan, will be also able to help you with that. I can't remember the figures off the top of my
I
head.
think
Um,
it's about it's about 11 9,000 plus watt to place and restore, I think.
yeah,
Yeah. But please have a look at the website. It'll give you an
yeah,
idea. Um, I think it's about 11,000, if I'm not mistaken, give or take,
yeah,
that including VAT. But no, I mean, if I get it wrong, then Alan will shoot me. So
yeah,
do have a look at it. It's out there. But that's for the whole
yeah,
residency.
for sure. If anybody has any other questions, that'd be great. Um, I'll use this time just highlight that our next Implant Threads meeting is on bear with me, the 25th of April, and it is with Majid Shabib, and we're talking to him about his journey from first placement to complex full arch. So I think that's going to be a really nice run through of Majid's experiences and what we can all take from that. Also, what I would like to announce is that we are developing and we're about to launch Implant Platform, which is different to Threads, in which that it is still a webinar based series. We're hoping to meet 4 times a year, and it's for people to come along and discuss their cases. We're going to have a small panel of colleagues, and delegates can come and present their casework. And it's really a platform for you to ask for advice, ask for alternatives, ask for just a bit of reassurance or anything like that. And it covers any aspect of sort of implant dentistry, from sort of planning, placement, restoration, guidance, anything like that. So there'll be myself, there'll be Wael Gurgis and Rohit Patel. We're going to be holding that. I believe the first one, again, Alan will probably shoot me when I get this wrong. I believe it's the 29th of April, Wednesday, the 29th of April, and that's 6:30, I think, UK time. But that will be sort of announced properly through our social media and online, and I'm sure we'll be sending out emails to our alumni about that as well. So that will be really good. It's not mentoring as such, but it's just a conversation for colleagues to have about cases. And yeah. If you do have any cases that you would like to um, present, please, if you can email me with your cases, or just get in touch, and then we can go through that together, and we can get you all set up for that, and anonymize it and everything. You can get me on my email, which is john@vssacademy.com or
.uk.
.co.uk. I always get that wrong. So it's John, John, at vssacademy.co.uk. And I'll be in touch with you and we'll take it from there. So, yeah, I'm just waiting for somebody just to finish off typing and we'll take it from there. So, yeah, thank you again, Manoj, for a cracking rundown. Um, It's
No,
it's been it's been really good, and yeah, from my point of view, I mean, I met you when I was just a wee lad in at the MSc, and it's been, and we worked together as part of that, with you mentoring me through the MSc, and then to still have you sort of mentoring me it's been, fantastic. It's been, a really great experience. So yeah, can't uh,
it's been
undervalue that.
it's
For
been a,
you, it's probably different.
no, it's been a pleasure, but it's been a privilege. I was the other day asking John about a soft tissue case. He's a bit of a soft
Yeah,
tissue czar. He's becoming one of the gods of soft tissue work.
yeah,
And I was struggling with something, and it was brilliant. The point is, I remember John as well, not just you giving me advice, you also send me the right papers on top. And
yeah.
that's the whole point, isn't it? Is the
It
evidence
is.
base behind it.
Yeah,
Uh, but I'm so passionate about this. It is a struggle. I do 30,000 miles driving a year, and I still love it,
good.
because it was invaluable for me. It was
Mhm.
absolutely invaluable for me when I first started. And it is a service I've been providing. Some of our colleagues are doing that with them. Ash does it with me. He does a lot of mentoring
Yeah,
now. He's brilliant at it. He also supports us at the training center. Uh, and yeah, we are getting more and more like-minded people getting
mhm.
into supporting each other. It
Yeah,
is otherwise a very lonely world. So
yeah,
yeah,
yeah.
get in touch with us.
It's
Make use
about
of us. It'll be an
building that
absolute pleasure
network.
to do that. Yeah,
Yeah,
absolutely. Just
yeah,
the case discussions are so valuable. Just to be able to discuss, even if one person puts the case together, there's just so much insight. There's so much you can take out of it,
yeah.
and there's so much you can course correct. And I think that's a great initiative about the case discussion platform. Uh,
Mm,
so yeah, keep an eye out.
yeah. No, it'd be good. Yeah, I think it'd be really interesting. We've Rohit, who if people know Rohit, he seems to attract really interesting cases. So I know he's already got a couple that he wants to discuss as well. Um, So yeah, and it'll be great just to get people on board. And again, yeah, like you were saying, it's about building a network, and it's about getting away from that feeling that it's me and my nurse in my little clinic, and it's the four
Yeah,
walls around me. It's so much more than that.
yeah.
Um, Christina says, thank you, gentlemen, for your hard work and for the informative course. So, mentoring is available for the level one certificate or only for level two and onward? My apologies for the question. Yeah, Christina's asking, do we offer mentoring at level one?
Yeah, mentoring is available at any point in time. Level 1, 2, 3, 10, 20. Uh, you can ask for and get mentored at any point in time. You could be someone who's starting off, or someone who's doing a few cases. So yeah, simply put, it is available. Yes, you have to be at least 2 years post qualification. You have to have been on a course. So if you look at the FGDP guidelines for implant training standard, it simply states three things. It says that you need to have a amount of theoretical knowledge, um, hands-on, and you need to be mentored. Those are the three pillars, if you like. So yeah, You could be mentored at any point in time. Long story short.
Fantastic. Right, well, I think what we'll do is we'll wrap it up from there. Thanks for everybody coming. Thank you for giving up your Saturday. It's been great to see you all. And again, thank you, Manoj. I
Thank you.
appreciate your time, and I'll see you all on the next one.
See you
Take
then.
care.
Bye,
Bye for
guys.
now.